sunny Pennsylvania. It is really sunny and hot. It's almost 95 degrees, I think. Here with me today, I have Dr. Justine Lee and Dr. Natalie Marks. So Justine, where are you logging in from today?
St. Paul, Minnesota, where it is 80 degrees, hot, humid, and thunderstorms all day. So hopefully the internet gods will be with us today.
I think your thunderstorms may be reaching me tomorrow. That's what my weather looks like. And Natalie, Dr. Marks, where are you logging in from today?
Downtown Chicago. And we actually have the first break in humidity that we've had in almost 3 weeks. So it's actually beautiful and sort of like 78, partly sunny. It's kind of a nice day. Yeah.
Awesome. So we want to hear from everyone. Where are you logging in from? And, type in where you are. We have our friend from Portugal. Love seeing you here. How's it going? Let's see who else. I'm looking down on my screen. Carolyn from South Florida. Hopefully you are staying safe. Everyone, of course. Cassandra from, as well, Chicago.
Hey.
Probably right near Dr. Marks. We have Washburn, Tennessee. Thanks, Tracy, for being here. Stacy from Jeanette, Pennsylvania. Hannah, maybe from around the corner from Justine in Minnesota. Oakland, California. Let's see who else. Massachusetts, Maryland, Texas, Canada. Hey, Stella from Canada. Andrew writes from middle of nowhere, Pennsylvania. Yeah, Pennsylvania is a pretty wide state, and that's a funny one. I appreciate that. We have Miami, Southern Cal, Minnesota, San Fran, Kansas, Iowa. I wonder if we wrote
a couple of Penn Wees out there and some of our resident mates out there.
I wonder if we wrote all these down, if we could really get a map of all 50 states on our session and how many other countries we could get. I love it. I love it. I love it. So we'll give everyone just another minute or so. I'm looking at my clock here. It's just after 1 o'clock Eastern, so I want to make sure everyone gets on. But wanted to welcome everyone. I love seeing where everyone, I'm keep looking at my list, where everyone is logging in from around the country and really around the world. So thank you so much for being here. And I think not to waste too much time, I'd love to get started and introduce everyone and really get all the awesome information we can about leptospirosis from Dr. Marks, our esteemed speaker here today. So you are all joining us today because we're going to be talking about leptospirosis, screening, testing, and treating. And please understand, this is a short 30-minute YouTube live event. It can't be as comprehensive as a 2-hour webinar, but this is pearls, awesome information. I've had the benefit of checking out Dr. Marks's presentation before you have, and I know we are all in for an amazing treat. So thank you, and we appreciate you all being here on your lunch break or your afternoon or whatever it may be. And I wanted to absolutely thank Merck Animal Health for their support and sponsorship of this afternoon's YouTube Live. They're an amazing educational partner, and it's with their generous support, we're able to provide this YouTube race-approved live event free to the veterinary community and the veterinary world. Now, if this is your first VETgirl event, very briefly, we are the tech-savvy way to get your online continuing education. We have large animal, small animal, technician-focused, leadership, real-life rounds, nutrition, practice management, all dedicated tracks for education. We deliver webinars, podcasts, blogs, and a lot more. You see on our screen, the webinar bottom of your screen. Our leadership track is not only RACE approved, but CVPM approved. We have a Spotify logo down there because you can find our podcasts anywhere you can find podcasts. Apple Podcasts, Spotify, radio.com, iHeartRadio, you name it, that's where we are. And finally, on the bottom, I hope you have learned that now VETgirl has launched, and we are very excited about our certificate programs. We've launched 4 so far. ER, basic, and advanced. We're just about to launch our practice management nutrition tracks, and we have more. So check out our certificate programs. It's another major benefit and perk to be a VETgirl member. Also, hope you're interacting with us on our discussion boards, on our forums. It's a great way to get case consults, questions, interact, vent over a coffee if you would like. But check out, for our VETgirl members, our forum and our message boards. And then, of course, as you know, YouTube is not our only social media platform. We have Facebook, Twitter, Instagram, LinkedIn. Just interact with us. We love showing you what's upcoming on any of our feeds. So make sure you like, fan, tweet, gram, whatever you do, just interact with us. Finally, very important, as I said, this is a RACE-approved event. So how do you get your RACE-approved continuing education? If you're not a VETgirl member, the only way to get this, So watch it live, okay? So what you have to do is comment in the YouTube feed. Screenshot that comment of our live YouTube feed and your comment and email. It's right on the screen right here. AnnMarie@VETgirlOnTheRun.com. Within about a week, we will verify attendance and send you an email with a link to download, print, and fill out your CE certificate. So comment in the YouTube feed, screenshot that comment, and email AnnMarie@VETgirlOnTheRun.com. With that said, I don't want to take up any more of your time. Justine and I are very excited and happy to have Dr. Marks with us today. So Dr. Marks, Justine and I'm going to drop us out of the screen, focus on you in the presentation. If you can, give us a little introduction, who you are, where you practice, and then take it away. I'm going to be behind the scenes as Justine will. We'll answer questions at the end. But Dr. Marks, again, thank you for being here with us today, and the floor is yours.
My pleasure. It's great to be with VETgirl again and to talk about one of my passions in veterinary medicine, which is infectious disease. So I've been practicing almost 20 years, 5 years in Atlanta, 15 here in Chicago at Blum Animal Hospital. I'm a mom of 3. I'm struggling through COVID, I think like all of you. But I find that these little blurps of getting us re-energized about what we're doing in practice is really helpful. So I wanted to urge, I am a practicing veterinarian on the floor, just like many of you are. And so I want these to be very practical tips that you can take with you, hopefully to your next case today or tomorrow, or bring it back to your team. So everyone feels better about how to do better for your patients and your clients and your team members when you're screening and testing and treating for lepto. So let's get going. All right. And again, thank you to Merck Animal Health for their ongoing commitment to supporting continuing education, especially in the area of infectious disease and vaccination. We really appreciate that. So lepto, it starts just like this, a drink of water, right? So it could be a stream, a lake, a pond, or that puddle in the backyard or the street in front of your house. And no sooner does that drink of water happen, then we end up with this, right? So 3 to 4 days later, the infection ensues, causing this leptospiremia, these bacteria going throughout the body, affecting a lot of different organ systems. But for us, predominantly seeing that as in liver and kidney disease, unfortunately, sometimes failure. So before we go into the screening and diagnosing of lepto, I want to just throw out a few reminders just to refresh. Remember, lepto is a disease that affects not only domestic animals and wildlife, but also people. And we know that it occurs not only in those rural hunting dogs, which is unfortunately the misconception I learned in school, but it's happening in urban and suburban areas all over the country. And it is one that we see starting usually with GI signs, those vague, vomiting, inappetent signs, diarrhea or fever, but it progresses to serious illness quite quickly, which is why the screening and aggressive diagnostic testing and treatment is so important. Lepto really, by many standards, is considered one of the most underdiagnosed and underreported infectious diseases that we have out there, because there are a lot of subclinical infections, those chronic carriers that we might be missing. So let's hopefully learn a little bit more about how this presents and where we could be finding it. So we're getting rid of not only that disease in our patient themselves, but also getting rid of that zoonotic risk to our families. Lots of different lepto reservoirs out there. Many of us think of the urban rat. That's what I see, unfortunately, here in Chicago. But we also see opossums and raccoons and skunks and squirrels. But I don't want to leave out those food animal reservoirs as well. For many of you that may be in more of a suburban or rural area, cows and pigs can be active reservoirs for many of those herding dogs or people that share on a mixed animal farm. So it's very important to remember that we should be screening with our clients if their pet sees any of these reservoir hosts, because that's a risk for transmission. We know, today we're going to talk mostly about dogs. Just for all those feline lovers out there, one big shout out, we can see this in cats. Rarely reported right now, but if you do have an outdoor cat that presents to you with fever, jaundice, potentially anorexia, just keep lepto on the list. Not saying it's number one, but it's got to be on there. Any age, though, any sex, any breed of dog is susceptible. Males and females, intact or spayed. If you have a dog presenting to your practice, we can't rule it out just because, again, it's not a puppy or it's not a rural hunting dog. In fact, drum roll, I don't know if any of you know that Jeopardy quiz question of which dogs actually we do see lepto the most in, but It's actually in our terrier groups, less than 15 pounds. And this beautiful Yorkie on our screen is the #1 breed for in-hospital prevalence of lepto. I mean, I was blown away by that. I don't know how many of you would have thought the Yorkie is the poster child for lepto right now, but Yorkies actually are. So what I want you to think about when you're kind of going and thinking, is Dr. Marks actually telling me the truth here? Think about how many of your lepto owners are reluctant to vaccinate against lepto, because I know tons of mine are. And my Yorkies come in here typically dressed in their outfit of the day, sitting on like in a Chewy Vuitton bag on their owner's shoulder. Many of those owners also telling me I would never vaccinate against lepto, or my breeder told me never to vaccinate against lepto. So a lot of that breed is really underprotected and potentially overexposed. So keep that in mind when you have that next Yorkie come into your practice. Lots of risk factors for lepto, right? So as I mentioned, those reservoir hosts, that indirect and direct contact with wildlife in their environment. For all of you contacting us and tuning in from these arid climates, you know, we think about lepto being more at risk in those wet areas, right? Heavy rainfall, moist climates, lots of water. We saw a huge outbreak of lepto in Phoenix in a dry, arid desert in 2016 through 17. Why did we see this? Well, sprinkler activity. So if you've got a lot of people with well-manicured lawns leaving those sprinklers on, even in the driest of areas, we still can see lepto. So don't forget about that. And as I mentioned, those urban rat populations, which, you know, are devastatingly, increasing in number, unfortunately, and we're seeing lots of different traffic patterns of those rats now because of COVID. Lots of restaurants and food sources for them are shut down. So we're seeing rats being more bold and going into backyards and alleyways and garages looking for sources of food. So we may have even more exposure than we did before. Remember, up to 90% of those urban rats are shedding this bacteria. Jason Stoll, Dr. Jason Stoll out of The Ohio State University, who's a leading veterinary epidemiologist. Many of you have probably seen multiple times during our COVID-19 productions throughout the industry. He did a great prevalence study focused in Chicago. We were one of the clinics part of that study. I certainly won't go through all the details right now, going through all of the study format, but I wanted to really point out to you some of the conclusions, which are really impressive, and to me were really stunning reminders that we're not doing a good enough job educating our clients of these risk factors. The study looking at 45 cases showed and really correlated well that this is usually more prevalent in smaller dogs, okay? Median size, you see 7.9 kgs, young and little overrepresented in males over females, but pretty equal. But here are the conclusions that to me are quite startling. 16 of those cases were under 6 months of age. Only one of them had even started the lepto vaccine series at their vet. To me, as a Chicago practitioner, I was really devastated to hear that, because part of these cases came out of my practice. So we are not doing a good enough job to get those puppies protected early and educate those clients and families of the risk of this disease. This was a fatality rate of 29%. We can definitely do better. This is the one piece, though, I think everyone should be telling their clients. Dogs that are not vaccinated for lepto were over 20 times more likely to be infected than a dog that had completed a full vaccination protocol. 20 times more likely to get a disease. We need to do better, and we need to be telling our clients this. So it's shed in that reservoir host. Oh, I'm so sorry about that. Oh, gosh. Matt. Everything just dropped in the middle.
Are you serious?
Yeah. All right, I'm back. Shut up, reservoir host. We can also see this from infection from contaminated water in contact with mucous membrane. And also from direct penetration through infected wounds. This is actually a second opinion case that came to me. And this dog had been told by a primary veterinarian to swim in Lake Mission for healing. And unfortunately, what ended up happening is not only this dog had a resistant staph infection, but also ended up sadly having leptospirosis from contact in Lake Michigan. So we have to remember that infected skin and wounds can also be a portal. The thing that we need to remember about with our cases in hospital is that we know that indirect transmission can occur with contaminated bedding. And that's really where we need to make sure that our entire team is trained appropriately, because we have a lot of team members that may be seasonal help, or they might be team members that haven't had the education that we've been privy to know about transmission risk. So if you have a leptosuspect in your hospital, you need to make sure that you can discuss not only in very obvious forms that is a leptosuspect for handling, for obtaining diagnostic samples, and most importantly, for cleaning up cages and disposing of bedding properly, dressing in full PPE and using closed-urinary catheters systems.
Hey, Dr. Marks, can you hear me?
I can.
All of a sudden, your audio must have changed slightly. There's a little bit of an echo. I don't know if there's something you can adjust on your end. We're getting
There's a large echo on my end too.
So we can take a slight pause, and I don't know if it's something you can adjust. I'll pop back out again, but I just wanted to let you know.
Is this any better?
Keep talking.
Is this any better? I'm not sure what else changed. I'm so sorry, everyone.
It's okay. I will drop myself out, and we'll see how it goes. Is there any chance you have something else like the feed playing in the background by itself?
I have nothing else.
Okay. All right. No worries.
Let's see if this gets better. It goes. So let's talk about our clinical signs. And if we can go to the next slide. We have our patients coming in, and again, I'm so sorry for this echo. I'm not sure where this is coming from, but we'll do our best. When we have our patients coming in, usually it's 3 to 4 days after they have an infection. And typically it is those GI signs: fever, vomiting, diarrhea, inappetence, sometimes abdominal pain. A lot of them can also be lethargic, depressed. In humans, we know that myalgia is a big problem. They have these muscle aches and almost this heavy feeling to them. We envision that most of our patients do have that as well. And sometimes this is missed for tick disease, because they may have that sort of walking on eggshells, tilted gait, but we can't forget about lepto, especially in these cases that have risk factors. They also can present with some of these atypical clinical signs, and that's what I really want to stress today. If you have a patient that comes in with conjunctivitis or uveitis, these are cases, again, that a lot of times we think tick, but we have to remember that eyes as the window to the soul can also be representing infectious diseases like lepto. So don't forget about this other spirochete that can cause these inflammatory changes in the eye. PUPD, again, a common reason. Sometimes they're even oliguric or anuric. Don't be fooled if your patient is not icteric. So only 12% or less of our lepto cases actually present with that clinical sign. We don't want to exclude lepto if icterus isn't present. Some of our patients can have abnormal bleeding, and many of them can even have a pulmonary hemorrhagic syndrome that they're recognizing more in people called LPHS. Here's the thing I want everyone to remember, though. Those are those acute cases, right? The ones that are clinically ill that we sort of think about from a textbook perspective. But we are recognizing now that up to 20% of our lepto cases are carrier infections. That means they come in for a wellness exam. These are dogs that come in and they're acting totally normal to the client, but they might casually mention a slight increase in thirst or an increase in urination. And typically it's brushed off as my dog's just getting old, having some accidents in the house. We can't ignore that subtle relationship that the parent is thinking about with that pet, because a lot of times that may be one of the only cues and clues that we should investigate further for possible leptocarrier infection. That's why history questions are so important, but the diagnostic testing is going to be the same. Oh.
Sorry, I was muted myself. Natalie, I think if it's okay, what we may do, just to see if we can improve the audio, is maybe to have you log out.
Okay.
And then use that same link to log back in. We'll just have everyone take a short pause and see maybe if we can have a quick fix to this, if that's okay.
That's fine.
Okay, so everyone's hang tight for just a moment. We're going to see if we can fix this. Hi, everyone. So obviously, we want to make sure that you can hear very well, and Dr. Marks hopefully should be logging back out and back in very quickly. We certainly appreciate your patience and want to make sure that we have a great presentation for you. So hang tight for just a moment, please. That sounds better.
Great. All right. Hopefully, we have a better feed here. Wonderful.
All right. So I'm going to drop myself back again. Bye.
Bye. All right, everyone. So sorry for the technical difficulties, even in COVID and all these Zoom meetings. For some reason, unfortunately, sometimes the internet here in Chicago dropped a little bit. For those of you that have had some difficulty hearing, I'm also happy to send these slides to you and certainly be available to reach out for any questions. I want to make sure you do get that information appropriately. So let's keep going with our cases. I'm a nerd at heart. I love to teach. And with some of our younger veterinarians, I try to encourage mnemonics and algorithms to try and get them to start thinking about differential list making. And this is one thing that I do think has been helpful when I teach around the country about lepto, is when to suspect lepto. How do we screen our cases appropriately? So if we have a patient that is elevated liver and kidney enzymes, that's PUPD, thrombocytopenic, or oliguric, if you have one or all of these, certainly you have a potential lepto case. Diagnostically, you have that acute presentation that came in, or even a chronic carrier case, like I mentioned, that PUPD wellness exam, which is happening more and more the more that you question. Look at your chemistries. So after you've collected blood safely and appropriate from a patient, 80% of dogs or even more will be azotemic, that elevated BUN and creatinine. If they have a serovar that's affecting the liver, they will have the liver enzyme elevation many times, with the alk phos being heavier or greater than the ALT. They could be hypokalemic because of GI losses, and certainly can have an elevated total bilirubin if they have liver affection. With the CBC, we also can see a stress leukogram, a neutrophilia, or a lymphopenia. Here's one pearl. Just like with your tick diseases, we can see thrombocytopenia, up to 58% of our lepto cases. So don't be like I was, which was blowing off that 130,000 or 150,000 platelet count. That could be one of your only clues to lead down the road for lepto testing. So thrombocytopenia is a big thing, and certainly your chronic carrier cases may have a non-regenerative anemia. You're also collecting urine. Please make sure, again, you're getting blood and urine as paired samples to look at this, safely collecting with PPE, of course. These patients typically will be isocinuric or hypocinuric. They can have glucose in the urine in over 50% of the patients because of proximal tubular damage. Certainly, they can have an active sediment with protein and bilirubin if they have liver affected. If you have a case that has pulmonary signs and certainly concern about that respiratory syndrome I mentioned, please take them. It's not very common yet, but we're recognizing it more and more. However, ultrasound is really something to be considering, right? So if you have a patient that you feel you have an ultrasound in your practice and you feel that could be suspicious for lepto, there's two somewhat pathognomonic findings that you'll see. That white arrow is pointing towards that pericapsular fluid band that you'll see, a lot of times pointing towards a suspicion of lepto. And then in that cross-section of the kidney, you'll see a brighter white horizontal band. That's called our hyperechoic medullary band. And we do see that from time to time in our lepto cases. Now, the testing. This is where I get the most questions. And certainly it's when do I do which test and what for? So let's go through the two that are most commonly used, gold standard being our PCR, right? So looking for RNA or DNA of this bacteria. The beautiful thing about this test is that it's not affected by vaccination. So if you vaccinated a dog last week and it comes in PUPD this week, you can still test. However, it doesn't detect serovars. You see here an example, it's positive or negative. So the limitation also about this test is that they're in our very paracute cases where you have an owner that's so astute and they say, you know, my dog normally eats 18 kibbles a day and today was only 17, I'm bringing him in. It may be too early to see a conversion on this test because it's detecting the RNA or DNA. So the blood is usually positive after 48 hours, urine is positive after the second week. So if you have a negative test, it's either not lepto or it's potentially too early. Switching though to the MAT test, that microscopic agglutination test, this is an antibody test. And the thing is we do need usually 2 serum samples, 7 to 10 days apart from the first. The first sample is usually negative in acute disease. That shouldn't be a surprise to anyone, obviously, because these are antibodies and they need time to form. We can't expect them immediately to be present in the bloodstream. It does require about 6 to 10 days post-infection. And you'll see an example here. You'll get a ratio of all the different serovars we can test for. And as we look at these, the confusion here sometimes lies in, is this from vaccination or exposure, right? Because we're creating antibodies and we need to know if this is a natural infection or one that we help create because of vaccine prevention. The vaccine titers, as a rule of thumb, are seldom higher than 1 to 800, whereas an active natural exposure infection, you'll usually see a titer that is over 1 to 1600 or higher. So as we look at this, feel free to screenshot these. They're pretty helpful. If your PCR is positive, congratulations, slam dunk, boom, you've got lepto in your patient. You've got an answer, time to treat. If the PCR is negative though, and every single mnemonic checklist is there, and it's a GI Yorkie who's never been vaccinated and comes in and you're really suspicious for this, it's either too early or there's not enough DNA there, or it's not lepto. Certainly in those cases, people say, well, would you treat? I certainly would start, but we've got to do additional testing to see if it's truly not lepto if you're highly suspicious. That's where the MAT comes in. So if you're using a SNAP tableside test, which is an antibody test, or the MAT testing, first thing to do is check if your patient's vaccinated. If they are vaccinated, remember, it's hard to determine sometimes between that and exposure. So run a PCR. But if they're not vaccinated, again, you've got your answer. Positive test, you've got lepto, we need to treat. Same thing with the PCR. If you've got a MAT test and it's negative, could be too early to see that antibody conversion, or it's not lepto. So how do we treat? First line of therapy, remember, this is a bacteria. We need to use antibiotics. Those critically ill vomiting patients that need to be in the ICU on intravenous fluid therapy, ampicillin, drug of choice, terminates bacteremia, 20 to 30 mg per kg IV every 6 to 8 hours. It's very effective, again, when we use it promptly and aggressively. But if you've got a well patient at home that is doing well and comes in for that classic, oh, my dog's a little bit older and has been drinking and urinating more, but is stable and can be taking things by mouth, doxycycline is your drug of choice here. 10 mg per kg once a day for 14 days, clears the leptospirosis from the kidneys. We've got to treat every dog in the household to prevent reinfection. For those critical patients, IV fluid therapy, a must. You'll see their fluid rates there are 2.5 to 4.5 times maintenance for LRS or norm-R. If you're doing this in the hospital, that's a heavy fluid rate. So you need to be monitoring ins and outs, watching for fluid overload, monitoring your output, again, hopefully in a closed collection system for your urinary catheter. And you want to warn owners that on average, we have to do this until they resolve their azotemia or clinical signs, which is 2 to 4 days in hospital. So give your owners some expectations of what's ahead. We do need to support them, of course, if they have GI signs. Use your antiemetic of choice. My preference is meropitant, 1 mg per kg once a day. There's also, of course, H2 blockers. Remember, kidney patients can have tremendous cytokine release, increasing the acid pumps in the stomach, which causes really severe reflux. So make sure you're protecting them with gastroprotectants. Again, use the one of your choice that you're comfortable with. I prefer famotidine myself. For your patients that have a serovar like Gripo that loves to attack the liver support also a must. Using SAMe to help with protect from the antioxidant damage and also help with regeneration. And then ursodeoxycholic acid, or ursodiol, is a wonderful choleretic. You know, leptospires love to hang out and hide in bile. So the more we can use this to flush that gallbladder, let the bile go into circulation and expose those leptospires, the quicker we resolve the leptospiremia. So in our patients that we do aggressive screening, aggressive testing, and make sure we get a diagnosis and start aggressive treatment, early treatment too. Survival is about 80% in our dogs, but it's poorer, unfortunately, with any of those patients that may have the complications of that LPHS, that pulmonary syndrome. So how do we protect our patients, right? We don't want to always be reactive and only seeing our patients that haven't been vaccinated, and then we're sort of behind the 8 ball with many of them because we might not see them right away with pet parents, especially in today's world of the pandemic. They may not be rushing in immediately with GI signs. Vaccination is key. So the gold standard vaccinations today protect against 4 serovars: Canicola, Gripo, Pomona, and Icterohemorrhagiae. These are new vaccines in the fact that they have amazing new technology called diafiltration. So many clients today still that I have will reference the vaccine of yesterday, right? The one that was highly reactive, and every breeder said, don't vaccinate a fluffy white dog, don't vaccinate a pug, don't vaccinate a dachshund, they're all going to react. That's no longer true. These diafiltration techniques have reduced the amount of protein in the lepto vaccine to make it much smoother and safer. And we know that kidney and liver disease occur much less often in our vaccinated patients. And that's, of course, our goal. Because with vaccination, we can start as early as 8 weeks of age, booster them at 2 to 4 weeks, and then do annual revaccinations. For those of you who have had lepto cases that you have treated and cured, don't forget to vaccinate them afterwards. They do not get lifelong immunity. We still need to vaccinate. But this vaccine prevents against leptospiremia, it prevents against thrombocytopenia, and most importantly, it prevents mortality. Again, I am so sorry for whatever blip happened here on my end, if that was the case. Here is my email and my phone number. Happy to send you slides of the short or longer presentation, as well as any questions in that little interlude where we had some technical difficulty.
All right, Dr. Marks, I'm going to bring myself back in, as well as Justine. She's coming back in 2, 1, countdown. There we are. Awesome presentation. And as many of you know, to get all of this information in such a short presentation, thank you to Dr. Marks for doing that. It's really hard to do that, but that's an awesome Cliff Note version of testing, screening, identification, and helping everyone hopefully really understand the importance of not only the disease and identifying it, but prevention, right? We, of course, want to make sure that we prevent rather than, as Dr. Marks said, react after the fact. So thank you to Dr. Marks. And again, thank you to Merck Animal Health for being a great educational partner in doing that. I'd love to get to some questions. Justine, did you filter out any questions yet?
Sure. Yeah, I've seen a bunch of repeat questions. So let's first start with testing. PCR, what can you tell us in terms of doing pre-treatment blood work, or how affected it is by antimicrobial therapy, and what the typical turnaround is? So what is your preferred? Is it MET or PCR?
Yeah, and that's a great question. And some of that depends on the patient. Some of it depends on how critical the patient is. Some of it depends on your client, how much they'll allow for testing, because the testing, of course, costs a different amount of money. I guess I would say this. I don't think there's necessarily a wrong answer, because you have 2 tests, right? So my point of view would be this. If I have an acute case, so let's say I go back to the practice today and I've got a 3-year-old terrier that comes in with GI signs, and the owner allows me to start with in-hospital lab work, which I always recommend doing, right? Because we need to at least get some baselines. And I've got azotemia plus or minus an elevated ALK phos or ALT. Well, I'm going to, in my area, I'm going to certainly have lepto on that list. For me, I would send out, because I have an active patient right there, a PCR test, because more than likely we're going to be able to get some kind of information, because I've got a lot of signs that are already pointing that way. If I have a patient that was already given antibiotics, right, it certainly can affect that a little bit, because you've already treated some of the bacteria. But if that's a case that has never had any antibiotic therapy, I'll send the test, and I start antibiotic treatment. The problem with some of these tests, at least for now, right, is there still is a lag time before we get things back. So that's the nice thing about having the option. If you do have a SNAP in-house, right, you can do a SNAP as a, I'm going to call it a screening test, right? Because there's going to be some times where that SNAP, as I mentioned, is either not going to be positive because it's too soon, or we really want to get confirmation and send that out as a confirmation PCR. But if you have that case, and especially if that case is a positive on a SNAP, you know that that dog's been infected for some time if there's been no recent vaccination. So I guess in summary, my MAT testing I use for my well patients. So I have a case I present that's a 14-year-old pug, totally normal wellness exam. Oh, by the way, he's been having urinary accidents in the house. Well, I don't need to do a PCR for that. I can start and get my first MAT sample, pull 7 to 10 days later, look for that 4-fold increase or 1 to 1,600. And certainly, again, I don't have to necessarily rush with IV ampicillin. I can send home doxycycline for that patient. It's those critically ill patients that I worry about sending out for a PCR. We've been getting a PCR test back in about 24 to 48 hours. But again, I don't wait. I start therapy because the worst thing is they've had 2 doses of antibiotics. The best thing is I've started early aggressive therapy, and it may be making a difference because we can clear some of those leptospirosis from the urine in 24 to 48 hours and decrease urinary shedding for in that home or in the hospital.
All right. And then another great question, what about our cats? So you mentioned, and there's definitely publications where cats have tested positive for it. Is there a vaccine? Is there a test? Should we simultaneously treat cats in a household where a dog was diagnosed with lepto? What do we do about our feline patients?
Oh, it's such a great question. And I wish I had all those answers for you. There is no vaccine yet. I would love to say they're working on it, but I would leave that to Merck, certainly, if they want to comment on that at some point. Usually what I've been told from experts far beyond my mindset is that if you have a case where, let's say, is certainly an outdoor cat that's been an active predator in the area and has been killing rats, and it's febrile and anorexic, and it's got elevated liver values, and it's azotemic, and everything's kind of like, gosh, this looks like a dog with lepto, but it's a feline, is to start antibiotic therapy. I have had some people anecdotally send out for a PCR. And to be honest, I can only say anecdotally that those tests have been negative, but I don't know, again, how the accuracy of it is. I know that right now the focus is predominantly on canines because that is the highest risk to humans. And most of the time, especially because I think people have been trained, pet parents more, that cleaning the litter box, the worry of, pregnant women and certainly good hand washing, I think people tend to be a little more cautious with litter boxes in general than that puppy that's having the accident on the floor and you've got a toddler over there and you're distracted and you just go over there and wipe it quickly. Well, we know, especially from that prevalence study in Chicago, that these dogs that are getting lepto and dying from it are our young puppies. And they're in the homes, typically with families. And you know how people are with puppies, and the puppies are all over and kissing all over and urinating all over. And it's really, to our point, it's really the thing that we need to be doing is as soon as that owner, especially now with the COVID puppy infusion that we've had, we really need to be educating from that very first visit about zoonotic disease. It shouldn't be a stranger to humans now to hear about zoonosis with COVID. So we need to be educating in day practice from day one, especially getting them started on that vaccine series early enough so that it's not 16 weeks and then you don't see that puppy for another year potentially. And then there's that huge gap in protection for that dog and that family.
All right. Great question on what do you do with a positive SNAP? Can it be from vaccination or is it always with infection?
Yeah, that's a great question. So remember, a positive SNAP is an antibody test. So it's very similar to the MAT test you would send out. So if you have a positive, you know one of two things, right? You either have had a recent vaccination that has created, we'll say, synthetic antibodies, right? So you've created the antibodies yourself with the vaccine, or that dog has had a natural exposure and has had creation of antibodies. So you know that you're in the right neighborhood somewhat, right? But we have to distinguish between the two. So that's where I send out for a confirmatory PCR. But if I have a positive SNAP, I certainly would start treatment, right? Because we don't want to wait and confirm, especially if that patient is clinical or has clinical ClinPath abnormalities that are suggestive that patient's going to get worse.
Excellent. What do you do if a dog just recovered from lepto? Like, when do you vaccinate him? And what do you do with the other dogs in the household?
Yeah. So that's another great question. And I don't necessarily think there's any literature to say exactly when you need to vaccinate. But for us, when I have a dog that recovers from lepto, I certainly do a follow-up recheck, a week to 2 weeks later, depending when that client comes in. We recheck lab work. Remember, one thing I didn't get to talk about because we have limited time, but remember, a lot of your patients that recover from lepto still have a high risk of being renal insufficient because they've had kidney damage, especially those dogs that come in quite azotemic. So you want to prep those clients that we're going to be great friends. We're going to get to know each other for the life of that pet because we need to follow their SDMAs and their urine specific gravities and their microalbuminemias and all those kind of things to see if there's any lingering or progressive kind of revealing, so to speak, of kidney disease. So I try to get that patient as stable as possible, but typically I'm revaccinating them 2 to 4 weeks after recovery. Every dog in that house should be vaccinated, right? Because if that one dog has had exposure, odds are those other dogs have the same daily risk factors or are going to be exposed to it from the other dog that goes maybe to a agility class or doggy daycare or goes out again to any of those reservoir host risk areas. You're very welcome.
All right. So thank you so much, guys. Fantastic information, Dr. Marks. And again, a huge shout out and thank you to Merck Animal Health for being able to provide this YouTube event. We hope you guys like it on YouTube. We used to do it on Facebook, but the good thing is you can view it whenever you want. Please make sure to press the subscribe button on your YouTube page right here. That way you can stay abreast of any new CE events that we have. And again, huge shout out to everyone. Please make sure to view this again or share it with your colleagues so they're aware. A lot of great points. And don't forget, small Yorkshire Terriers, 10-pound dogs in an urban environment. Please, no antibiotics before you do that PCR test. And the prognosis is about 25% of dogs die from this, and it's preventable. So again, really important that we educate our owners with that. And with that, I know you guys are swamped doing curbside. Who gets a lunch break nowadays? So thank you for all that you do to save lives, whether or not it's through vaccination and prevention or working ER or working in government. It's a thankless job at times. And we just want to thank you guys all for rocking it. And again, please don't forget, you can get half an hour of free CE by watching this live only, okay? So when in doubt, you can take a screenshot of your comments, email it to AnnMarie@VETgirlOnTheRun.com. That's in the comment section below. Give her a couple of days to respond to hundreds of emails, but we'll make sure to get your CE certificate. And Dr. Marks, thank you again so much. Fantastic information. And with that, stay safe all and mask up.
Bye-bye, everyone.
Bye.